We want to update you on DVS's telehealth technology platform and our new go-to-market plan to teleport vision care and specialty medical services to Oakhurst Medical Center and other primary health care centers in Georgia. The last time we visited, we had assembled our Vision Optimizer prototype at GCMI and finished a successful clinical demonstration trial at Georgia Tech, and we were showcasing our system to potential customers in the optical industry. To recap, the Vision Optimizer is the first telehealth platform for vision care, which allows eye exams to be conducted remotely through the internet without the need for an on-site eye doctor. We have a high-resolution refraction system that creates a new category of ultra-high definition, premium price corrective lenses that we derive royalties on, and we created an optical preview feature to upsell customers to premium lens products and the sale of second and third pairs. The industry problems that we were addressing were caused by the century-old phoropter that was error-prone and couldn't provide measurement resolution that modern digital lens fabrication technology can now provide. The need for a $150,000 on-site doctor to manually spin the dials of the phoropter limited access to vision care and drove cost. And the whole vision test was a lousy consumer experience. Using our prototype at GCMI as a showcase, we compiled a number of firm and potential customers, including NVI, the fourth largest optical retailer that operates America's best brand, and Hoya and VSP, the second and third largest manufacturers of spectacle lenses to the independent channel. Following successful pilot trials, these customers cumulatively represented the opportunity for DVS to place over 10,000 units into the North American market. While these customers loved the features of our prototype, they wanted a production quality device delivered to their stores and ECP customers for pilot testing. We partnered with Plexus, a gold standard Wisconsin-based contract engineering and manufacturing firm, and created a plan to design and build units for our customers, first at GCMI and then transferring manufacturing to their Neenah, Wisconsin facility. We determined that a total of about $6 million was needed for this effort. With our customer orders and plan with Plexus in hand, we set out to raise $6 million in equity from strategics, VCs, or private equity investors, or a combination of all of them. We attended the Southeastern Medical Device Manufacturing meeting in Nashville in May, competing against 15 other companies pitching to 22 VCs and other investors in the medical device industry. DVS won first place in the competition and voted best company and most attractive deal. But we found that virtually no one was investing in pre-revenue medical device companies in the Southeast. Over the past few years since the Affordable Care Act was passed, with its medical device tax, the number of deals had fallen by nearly half, and the few investments that were being made were in later stage businesses. We then began to explore alternative strategies for commercial entry that required less capital to be raised and that permitted an earlier entry to market and reduced time to revenue. We were particularly interested in finding a way to deploy our existing prototype into a revenue-producing opportunity. We wondered what other customers outside of the optical industry needed our telehealth system for eye care, and if our existing platform could be adopted to meet unmet needs in the telehealth space. This search led us to visit the Department of Community Health. The DCH is the state agency that is responsible for a $12 billion budget and for administering state-funded healthcare programs including Medicaid, Peach Care for Kids, and the State Employee Benefits Program. Senior DCH staff educated us about the unmet need for a new healthcare access point for the large medically underserved populations throughout the state, to provide for ER diversion sites for hospitals, vision and hearing tests for school children, and to bring specialty medical care to federally qualified health centers and other primary care providers. Our telehealth technology platform is uniquely suited to address these needs. FQHCs are typically community health centers that provide outpatient primary care services to underserved patients. FQHCs are certified by the Department of Health and Human Services and receive grant money to care for patients with no insurance. FQHCs have grown tremendously under healthcare reform, where they serve as medical homes to the newly insured. Today, there are over 9,000 clinics caring for nearly 25 million Americans. In Georgia, 27 FQHCs provide health care for over 400,000 patients. The Oakhurst Medical Center in Stone Mountain is one of Atlanta's leading FQHCs and the 7th largest in Georgia. OMC provides care to 20,000 patients through 45,000 annual encounters, seeing up to 175 patients per day, where they provide primary health care services in their main 24,000 square foot clinic. These services include family practice and internal medicine, OB/GYN, and pediatrics. Part-time specialty services such as dental care are also provided on certain days of the week. Many OMC patients have multiple chronic conditions such as diabetes, heart disease, hypertension, obesity, and arthritis that require care from the primary care doctors at OMC and from off-site medical specialists. Each year, 60% of OMC's patients require off-site visits to see a medical specialist or to obtain a medical imaging study. Over a 12-month period, OMC patients required 4,000 medical imaging studies and 7,000 referrals to off-site medical specialists. The most commonly needed specialty medical service at OMC is eye care, accounting for over 23% of all off-site referrals. OMC also cares for 5,000 school-age children who are now eligible for annual vision exams, which can detect sight-threatening conditions such as strabismus, and a biannual benefit for eyeglasses. Today, an OMC primary care patient with multiple chronic conditions must shuttle between her primary care provider at OMC and multiple off-site medical specialists. Having to travel to numerous specialists is a hardship and costly for patients, and it impairs the coordination of care. In many cases, these patients simply fail to receive the specialty care they need. And this is the same story for preventative care, such as eye exams for diabetic patients and mammograms for women at risk for breast cancer. To solve these problems, we envision deploying our HealthPort telehealth system on the OMC campus to provide eye exams to OMC patients from remotely located optometrists and ophthalmologists. By partnering with medical imaging companies and other healthcare providers, we could use our proprietary telehealth platform to deliver other medical specialty services needed by OMC's patients. As shown in this table, medical imaging and other diagnostic technologies provides the information necessary for other remotely located medical specialists to provide care to OMC's patients through the HealthPort. We pitched the idea for an expanded functionality telehealth platform to GE Healthcare, one of the leading suppliers of medical imaging technology. They really liked the concept and offered to provide us with a DEXA unit, a mammography system, and an ultrasound scanner free of charge for a 1-year pilot trial to provide medical imaging services for OMC's women health practice through the HealthPort. DVS and OMC recently entered into a term sheet for a 1-year pilot trial of the HealthPort, which will be located on OMC's campus, to provide specialty medical services including medical eye care, optical retail services, medical imaging studies including mammograms, DEXA scans, and ultrasound. We will also provide ENT and allergy teleconsultations and other specialty consultations through the HealthPort as needed by OMC's PCPs and their patients. In addition to GE Healthcare, other partners supporting the trial include the Piedmont Radiology Group, the ENT Institute, and 2 IT software vendors, Athena Health and Ramsoft. The HealthPort will function as a clinic within a clinic, or if you like, a specialty clinic operating within a primary care clinic. This next series of slides shows how the HealthPort will operate. Here we have diagrammed OMC's clinic with a waiting room, front office, and exam rooms where the primary care physicians see patients. Today, the PCPs send patients off campus to receive specialty medical care and consultations. When the HealthPort becomes operational, the PCPs will direct the patient who needs a specialty consultation or service to the HealthPort desk to be worked in on the same day as their PCP visit. A second major source of HealthPort patients will be to identify OMC patients who need HealthPort services in advance of their PCP visit. We will query the OMC database to identify patients in need of preventative services by searching on ICD codes. In this way, we will be able to identify diabetic patients who need eye exams, at-risk women for mammograms, and patients with osteoporosis who need bone density test. We can identify these patients and schedule a HealthPort exam on the same day as their PCP visit. Finally, OMC patients will be able to electively schedule services. We will collaborate with OMC to make their patients aware of the availability of these new HealthPort services through TV programs in the waiting room, point of service material, coupons, etc. Because we will be using the same cloud-based EMR platform as OMC, their staff can schedule appointments in the HealthPort, and we can pass consultant reports to their PCPs in a seamless fashion. The HealthPort will maintain a group of medical specialists who are on call for teleconsultations for a half day or a full day of coverage. Once the patient workup is complete, the specialists are notified by email or text message, and they log into the HealthPort system for a live, two-way teleconsultation with the patient in our exam chair. We then complete the medical record, generate a CPT code, and bill the payer, or in the case of elective services such as eyeglasses, collect directly from the patient. We created a forecast of the annual revenues generated by a HealthPort deployed in an FQHC clinic with 45,000 annual patient encounters. We based the forecast on historical specialty referrals and medical imaging studies by the OMC Medical Center, an analysis of the demographics of OMC patients, input from OMC management, and specialty referral rates published by the National Association for Ambulatory Care. We use this information to forecast the number of HealthPort encounters for optical retail services, medical eye care, medical imaging and diagnostic studies, and teleconsultations with medical specialists. We assume that vision exams and 2 pairs of eyeglasses will be purchased for $104, a typical average selling price for discount optical retailers. For healthcare services reimbursed by insurers, we base the reimbursement level for these services on the lowest published CPT reimbursements by the Georgia Medicaid program. We expect that a HealthPort deployed in an FQHC like OMC will provide a broad and diverse base of services and generate about $1.8 million in annual recurring revenue. The expenses required to deliver the services are listed here, including staff and professional services through teleconsultation. DVS expects that the HealthPort teleconsultation platform will cost $45,000 to build, and that this cost and the cost of medical imaging equipment will be amortized through a capital equipment lease. Other expenses include health IT and billing services, a HealthPort manager and optometrist, marketing cost, and allowance for bad debt. We expect that a single HealthPort will contribute about $400,000 in annual profit, a contribution margin that will increase when 5 units become operational to serve a local area, because a single manager and optometrist will be able to supervise a 5-unit pod of HealthPorts via telehealth. After meeting with the management of several leading FQHCs and the Georgia Association of Primary Healthcare, which represents all FQHCs in the state, we believe that these health centers are the ideal initial channel for deploying the HealthPort in providing a major unmet need to deliver vision care and other specialty medical services to the primary care patients on their campuses. DVS is proposing to raise funds to open HealthPorts in the 10 largest FQHCs in Georgia, with the first 5-unit pod located in North Georgia, centered in and around the Atlanta metro area. We then plan to open the next 5 units in Central and South Georgia, giving us 2 fully operational pods. Here's what the operational plan looks like to achieve that rollout. We can open the OMC HealthPort and a second HealthPort by raising as little as $750,000 in convertible promissory notes that will be described shortly. We plan to open OMC about 4 months after closing, and then take a few months for a shakedown cruise and to ensure telehealth operations are working smoothly, at which point we will move the manager and the optometrist off-site. Then, beginning in month 7, we will finish and deploy our next 4 HealthPort units and deploy them into FQHCs in the North Georgia market, finishing out the first operational pod by January of next year. We will then start deploying HealthPorts to FQHCs in Central and South Georgia, which will give us a good story and operating history to raise $8 to $10 million in an institutional round. These funds will be used to scale the HealthPort business model to FQHCs in other states and to explore other channels for our technology. The telehealth platform for vision care will remain an appealing offering to the optical industry, and in addition to the FQHC channel, the expanded functionality HealthPort has many potential applications for primary healthcare providers and for integrated healthcare delivery systems. This model shows us deploying about 130 HealthPorts over 4 years, and then seeking a strategic or financial acquirer of the business after this period of time. 130 operating HealthPorts will generate $182 million in revenue and a projected EBITDA of $32.4 million. Using these numbers, we computed the value of GRA's investment and your related entities that have existing investments in DVS, assuming that you will make 2 $500,000 investments in the present deal. The ATDC seed fund has a $50,000 investment, and there is another $250,000 investment in DVS that is split between these two funds. Selling the business at year 4 at a multiple of 8 times EBITDA shows that the total distribution from these various investments would total $9.6 million and provide GRA with an excellent return on investment. We intend to fund the market entry of the HealthPort with a round of convertible promissory notes that are summarized here. These are the same terms as all prior investments in DVS. The notes will convert into preferred stock with a minimum future equity investment of $3 million or more. The notes carry an annual interest rate of 7.5% and mature in 3 years. The investors are issued $1 warrants in proportion to the amount of the note, and the notes give the investor the option but not the obligation to participate in future Series A financing. We intend to raise a minimum of $750,000 to launch the pilot trial at OMC and to build and deploy a second HealthPort in an Atlanta-based FQHC. We intend to raise a total of up to $2 million, which will provide the funds necessary to build, deploy, and open 10 HealthPorts in the largest FQHCs in Georgia, placing us in excellent position to raise an institutional round to scale the business model. For this round to fund the HealthPort's market entry, we hope that GRA will invest up to $1 million in 2 $500,000 tranches. We've identified at least 3 new co-investors, and several existing investors are interested in participating in the offering. We have also had discussions with institutional and strategic investors who are interested in providing equity funding to scale the HealthPort business model following a successful commercial pilot trial. These slides summarize the value proposition that the DVS investment opportunity brings to the market. For the healthcare industry, DVS has developed a novel clinic-in-a-clinic telehealth model that is based upon the company's proprietary technology platform. The HealthPort will increase access, reduce cost, and enhance the quality of healthcare, and address a major unmet need to integrate the delivery of primary and specialty care. The HealthPort model can thrive under any conceivable revision of the Affordable Health Care Act because it offers the most efficient and cost-effective means to deliver specialty health care to primary care patients. The flexible architecture of the HealthPort will allow services to be tailored to the needs of the primary care provider and to add new services and revenues to the platform over time. For investors, DVS has dramatically reduced the capital needed for market entry from $6 million to less than $1 million, while simultaneously increasing the recurring revenue per deployed unit by more than tenfold. We have also significantly reduced time to revenue and profitability by deploying our existing prototype into clinical service and by partnering with others to expand the scope of services offered through the HealthPort. All of these efforts will significantly increase the enterprise exit value for DVS investors, as the business will appeal to a broader range of acquirers in the healthcare industry over a time range of 4 years or less. While DVS investors will have the option to participate in future financing opportunities for the company. Finally, we believe the DVS HealthPort investment opportunity is a good fit for the Georgia Venture Fund. DVS is a venture lab company that was awarded Phase 2 and Phase 3 grants and put the funds to good use to design and build the functional HealthPort prototype. DVS benefited from collaboration with GTRI and the Electro-Optical Systems Lab, whose staff helped the company design its novel optical system. DVS was one of the first companies to be housed in the Global Center for Medical Innovation, where it assembled its prototype and conducted a successful clinical demonstration trial. DVS's successful entry to market will create another example of the Georgia Research Alliance fulfilling its mission to help new job-creating startups emerge from the state's technology ecosystem. DVS will create many new high-paying jobs for Georgia citizens, especially in high-paying engineering and manufacturing jobs for engineers from Georgia Tech and from the state's other universities. These jobs will contribute to the local economy and strengthen the tax base. The HealthPort's telehealth platform has the potential to increase access to healthcare, particularly for Georgia citizens who are underserved. At the same time, through economies of scale and elimination of redundant facilities and staff, the HealthPort has the potential to reduce the total cost of healthcare for programs that are paid for by Georgia taxpayers. DVS will be in a position to contribute to Georgia's leadership in health IT and in telehealth technology for many years in the future.